This is the second lecture of rhythm abnormalities or rhythm and how to assess the rhythm. First of all, a quick recap. It was normal sinus rhythm. Then there was sinus bradycardia, sinus tachycardia, sinus arrhythmia, which was that difference between with inspiration and expiration. Then there was sinus pause or arrest. Then there was sinoatrial block. There was ectopic atrial tachycardia. In ectopic tachycardia, it was regular. P wave was present with similar morphology, just different morphology because of one ectopic pacemaker. Afterwards, there was wandering atrial pacemaker, in which we saw that there are more than 3 morphologies of P waves and rate is less than 100, right? And in multifocal atrial tachycardia, rate is greater than 100. Rhythm is irregular. Both are approximately the same thing. Just P wave has more than 3 morphology. P wave has more than 3 morphologies. Just difference is that rate is greater than 100 in multifocal atrial tachycardia and less than 100 in wandering atrial pacemaker. Okay, first, now moving on to important ECGs. These are the ECGs which you need to pick, right? So first of all, first ECG of them is, which is really important, is atrial flutter. So how to identify atrial flutter? Atrial flutter has a different rate. It is 250 to 350. It is very high rate in case of atrial flutter. Similarly, in ventricular flutter, it is going to be 125 to 175. Rhythm is going to be regular. The P waves would be flutter waves, right? I'm going to show you this. Then P to QRS ratio is approximately 2 to 1. There are going to be 2 P waves for 1 QRS complexes because atria are beating at very high pace. PR interval is going to be variable. QRS width is however going to be normal because ventricles do not have any problem. There is no grouping or any dropped beats, right? So let me zoom it and show it to you. Here you go. Here P waves are shown as flutter waves. Okay, this is a P wave, then QRS complex followed by T wave, right? This is T wave and then again P wave, and so this trend is followed everywhere, right? So basically, atria are not contracting; they are fluttering, and by fluttering I mean that they are not moving in a coordinated fashion to move blood. They are just if this is complete atrial wall, it is just vibrating kind of. It is not contracting like it should be. It should become smaller and smaller and smaller and push the blood into ventricles. So it is just fluttering. Most of the times you can pick it from the rate. If it is very high rate, it is regular rhythm, and P waves are flutter waves, it is going to be atrial flutter. Easy ECG to pick. Next on we have atrial fibrillation. Okay, so it is a benign process, usually benign, but it can cause hemodynamic instability. So what is going to happen? I'm really sorry for the ECG because it is not showing you, but let me show you how it is like. Here there is T wave present, but in this there is going to be T wave here, but there is no P wave. Then there is QRS complex, no P wave. Direct QRS complex, T wave, QRS complex, T wave. So P wave is absent. There is no P wave because of loss of sinus node. So this condition is called atrial fibrillation. So atria is not contracted in a coordinated fashion. Atria is just getting depolarized, and in flutter it was moving really fast, and it is not contracting at all. It is not contracting, but it is it is kind of just not pushing the blood. Rate is going to be variable because there is no sinus node, there is no pacemaker. Rhythm is going to be irregular. P waves are going to be chaotic if present because of fibrillation. In fibrillation, always remember that P waves are going to be chaotic. P to QRS ratio is going to be none because there is no P wave. PR interval is going to be none. Then QRS width is going to be normal. Grouping and drop beat would not be present. This is atrial fibrillation. Here you go. Okay, so till now all of which we studied were part of tachycardias. Now we are going to be going into these bradycardias or bradyarrhythmias, right? Okay, so I told you that in case of sinus node, rate is 60 to 100. If this is our heart, right? So this is sinus node, this is AV node, this is right. So this has 60 to 100. AV node has however 60. So if by somehow atria get electronically ventricles, then this AV node is going to take the charge. In that case, rate is approximately 40 to 60 because AV node has capability to generate the current of approximately 40 to 60. Then rate is going to be regular because pacemaker is present and pacemaker is AV node. There are no P waves, antegrade or retrograde. And then P to QRS ratio is similarly none, right? So in this ECG, you can see that there is no P wave, right? QRS complex is present, T waves are present, right? And rate is approximately 40 to 60. So we can say that it is AV nodal rhythm, right? It is going to be between 60 to 30 because a pacemaker is present, junctional rhythm is present, so it is going to be regular. P waves, if present, are going to be none and anti or retrograde. Similar to all others, there is no P wave, QRS complex is present, T wave is present, right? So similarly, PR interval is none, QRS complex is normal, there is no grouping or drop beats. Now we are covering the arrhythmias which have hemodynamic significance. This is idioventricular rhythm. In idioventricular rhythm, it is going to be 20 to 40 per minute, right? So in this case, AV node is also knocked out. And then there is no junctional rhythm. This is provided by any part in the ventricle. So it is going to be 40 to 60. It is going to be regular because there is a pacemaker present. P wave is absent because sinus node is not present. P to QRS ratio is none. PR interval is none because there is no P wave. QRS width is wide, right? This rhythm is wide because the current is passing through the ventricles for more amount of time. In ventricular rhythms, you are going to have wide QRS complex. Just remember this thing, right? And if at all present, it is going to be bizarre. There is no grouping or drop beats. It is called idioventricular rhythm. Only thing which are different is QRS width is wide and bizarre. and the rate is 20 to 40 per minute. Now, if it is an accelerated rhythm, it was 20 to 40, it is going to be 40 to 100. But similarly, you can see the QRS complex width is wide and bizarre, right? Let me highlight this for you. Same, there is no P wave present, right? Rhythm is regular and it is 40 to 100. So it is an accelerated idioventricular rhythm. Ventricular tachycardia, right? Here you go. This is a very important ECG, right? I'm going to write important on top of it because it is that important. Rate is 100 to 200. There is no P wave, and if it is present, it is buried because any ventricular thing part has taken control of the rhythm. It has suppressed sinus node, right? And rhythm is regular because there is a ventricular pacemaker present, right? That's why it is called ventricular tachycardia. There is ventricular pacemaker present. There is no P to QRS ratio because there is no P wave. P interval is none. Q wave is wide and bizarre. Remember, ventricular tachycardia, if there is one word which you can remember is if there is tachycardia in ECG and you find wide bizarre QRS complexes like you see here, right? Then it is most likely going to be ventricular tachycardia. There is no grouping and there is no fusion beats. Similarly, here you go. Okay, here we are going to see fusion beats and capture beats, right? So in this ECG, you will find somewhere that there is going to be a fusion wave present, where there is mix between ventricular tachycardia and sinus morphologies, right? This is ventricular tachycardia going on, and then this is this part right here. This is sinus, QRS complex and P wave. So this is ventricular tachycardia, but it has fusion beats and it has capture beats. Capture beat means that when finally there is a P wave and there is a QRS complex which follows an T wave, capture beat. Similarly, fusion beat is like, you know. Okay, moving on to Josephson sign and Bugada sign. There is small notching near the lowest point of S wave, right? This is an S wave, and here you can see here is the notching, right? So this is called Josephson sign. And then there is Bugada sign. In Bugada sign, interval from R wave to bottom of S wave is more than 10 seconds, right? This interval is more than 10 seconds, 0.10 seconds, right? So these are four signs in ventricular tachycardia. Number 1 sign is fusion beats. Number 2 sign is capture beats. Number 3 sign is Josephson signs, which means that there is small notching near the lowest point of S wave. And there is Bugada signs, which mean that interval from R wave to bottom of S wave. So if like here is an R wave and there is bottom of S wave, this interval is going to be more than 0.1 second. Okay, now these two ECGs, this one is rare, but these two are potentially lethal, right? So in this rate is going to be 200 to 250 beats per minute, but it is going to be irregular, but irregularly regular, right? There are no P waves. Since there are no P waves, there is no P to QRS ratio or P interval. QRS width is variable. And previously we've seen that it was widened and bizarre. Here it is not. It is variable, right? You cannot say here it is different, here it is different. It is a form of ventricular tachycardia, torasedes D points, but they are shaped like these sine waves, right? They are shaped like these. The potentially complication of torasedes D points is ventricular fibrillation, which is the only rhythm abnormality which is definitely lethal, if not cardioverted, right? So in ventricular fibrillation, here you can see that there is an intermediate rate, indeterminate rate. You cannot determine the rate because there is no particular R wave present. Rate is irregular. There is no P wave. Since there is no P wave, there is no P to QRS ratio or P interval. QRS width is none because there is no QRS complex, right? So this is your, if these are your ventricles, right ventricle and left ventricle, they are not contracting like we study in fibrillation. They are not getting shorter and shorter and shorter and pumping blood outside. They're not doing that. They are just, you know, kind of vibrating. So this is not potentially, this is actually lethal. There's no grouping or drop leads. So this is ventricular fibrillation. The only ECGs which needs emergency treatment. Ventricular tachycardia also needs the treatment. So these are four signs. Just quickly revising through it, right? So ventricular tachycardia, wide complex tachycardia is ventricular tachycardia, right? Then idioventricular rhythm, there is ventricular rhythm, but QRS complex width is wide or bizarre. There is no P wave present. And if it is 40 to 100, then it is accelerated. Junctional rhythm and accelerated junctional rhythm is the same thing. Just difference is between the rhythm. Just the rate is different. 60 to 30 and 40 to 60, right? Then here in this case, atrial fibrillation, atrial flutter, right? These are kind of potentially difficult things and kindly things which should be. So I've taken a lot of time on rhythm, but these ECGs are tricky, important. I'll be uploading different exercises on it, so don't worry if you didn't get it. Just keep it from theory point of view, and afterwards we'll be discussing each and every ECG of them individually in an actual patient. So with that, give me a like and subscribe, and thank you very much for listening.